probably a good thing to do next, Julie and Carl, is to go through the template on screen so that people can see how to fill it in, and you can emphasize what's important to definitely fill in. We're all pressed for time, I guess, in practice, and we might sometimes need to move through and skip some of the boxes, but it's important to know the ones that are really, really important to make sure we complete. So I'd be keen to focus on those things. So I think we're going to have to look at some slides to go through it. So let me bring those slides up, and over to you, Julie.
Thank you. So you've got a patient that you think is likely to be approaching end of life. Maybe they're becoming more frail. You may be asked the surprise question, and they haven't yet got on EPaCCS or have a respect form. So we've got here the launch page of the EPaCCS tool, which has a number of useful resources on it. And it's a contents page as well as a quick link to various things. If we go on to the next one, it'll bring up the initial information page. So there's a few boxes on here that don't need to be used now, and they will be disappearing fairly shortly with the current EPaCCS review that's underway. So you will see here that you can put the initial diagnoses in. One tip for quickness, I tend to copy and paste the list of diagnoses because it doesn't automatically pull from the system, because the system's not clever enough to know which ones are critical for end of life. We'll free text them in, but you can save time by copy and pasting that into the respect form that you'll be subsequently doing. So key information here will be the things like carers. A lot of people miss that, but it's there for a reason, because we need to be supporting our carers. And actually, as a system, we're not as good as we could be at supporting our carers as deemed by questionnaires that go out to carers. So that's a flag up for that. Formal care, that's also useful to have a think about at this stage, because the patient may or may not need care. They might already be known to the district nursing team, and it's useful to record that information. The refer to Nottinghamshire EPaCCS box will be disappearing very shortly because that's no longer necessary. So next tab. So you'll see these are, okay, right.
There we go.
So we have the blue page up here. So this is for our patients who may not be technically end of life. So they may not be in the last 12 months of life, but we know they would benefit from advanced care planning. So these...
Julie, I've got a question, Julie, because many of the people watching this might be sort of GPs or quite experienced members of staff who are familiar with kind of initiating these conversations, but we're increasingly asking wider members of the team to start having these conversations. And what's a good way to start an end of life conversation with somebody in this blue box, because they might not appreciate quite how unwell they might be, or the need to have this conversation. Have you got any tips? For
yes, good question. So there'll be various flags that will be triggers for us to be thinking in this way. So those might be someone's just been in hospital with an emergency admission. They might have had a fall or been in hospital with an infection. The hospital may or may not have picked them up for that they need advanced care planning, but it may well be evident to us that that would be appropriate. So that's one key cohort. You'll see next under the indicators, we've got multiple organ failure. So your eHealthScope workflows might have picked up that someone's got an MRC score of 4 or 5, or they've got advanced heart failure. They might just have had a recent diagnosis of dementia, and you want to start some advanced care planning before they lose capacity, a prompt to get their power of attorney set up. That would be another example. Or you might just be aware of the fact that they're increasingly frail and in need of more support.
Yeah, often we pick these patients up, as you say, after an event such as a discharge or a change in their health, or a kind of a routine review when you think actually we need to, or we'd benefit from having this conversation. And I often frame it as a planning sort of conversation. I say it's an opportunity to just pause and plan. And you might not be there yet. You might not be there for a long time, but you won't be able to tell us when you get there potentially. So we need to think about this now. Shall we go
absolutely.
that's the sort of approach we often take. Yeah. Anything else to say on this before we move on to the next slide for those blue patients?
You can see the clinical frailty scale on there. Our System 1 modules will also be prompting us to complete clinical frailty scores. It links to the template. So a key shout out, we have a lot of work happening around support for frailty now. So just a reminder to people that if to be thinking about what their clinical frailty scale score is. And again, that will help us determine what kind of support they might need at the moment.
Yeah. And I find each of these tabs just a really good thing to work through from top to bottom. I think it's really structured really nicely. So just move through each of them and fill out, what you can, and it prompts you to think about do not resuscitate or CPR status, and have that conversation, and prompts you to start completing that respect form to record their wishes. So that's all there, which I find really helpful.
Yeah, thank you. A lot of work went into thought went into this. Surprise, surprise. So I'm glad you think so. So if we've got a patient who has progressed a little bit, the surprise question, would we be surprised if they died in the next 12 months? If you can say yes to that, then they're green. But they may still be quite stable. So you can see we've got preferred place of care and preferred place of death boxes here. Really important, as we discussed earlier. Deprivation of liberty is not going to apply to many people, but it's worth considering for a few. You can see that we've also got a box for the SR1 form. As an ICS, we're not really remembering to do this very much. So we're looking at trying to make it a bit more obvious on the template. And I guess this is a key in for having the conversations with patients, because we can give them practical, beneficial support financially by getting the SR1 completed. And for those that don't know, it enables people to get high rate disability living allowance without a delay, and it saves a whole lot of headaches with paperwork as well. Really easy to do online now.
It's the old DS, it's the new DS 1500, isn't it?
It is, but it kicks in at 12 months, not 6.
So, and there's a link out, and the template has lots of these links out to relevant forms or other templates which are useful to help complete data entry or to kind of information websites as well. So they're all really, really useful.
Yeah. The LPA is also important to record, because as we know, power of attorney is legally binding, and we need to have copies ideally of power of attorney paperwork for health and welfare on our systems, because we're legally obliged to follow them. A lot of patients don't realise that, actually. I normally have to prompt people to let us have a look at it.
Yeah, and if you go through that process with a relative, it does tell you to provide a copy to your GP, but it's important that we ask for them. Okay, let's carry on.
Social care needs, again, we often forget that the patient may have social care needs, but also the carer may have social care needs. And a common reason why certain patients, dementia being a key one, our Admiral nurse colleagues tell us that a lot of dementia patients are now arriving in A&E with social needs because of carer distress. So it's something that we need to be aware of, and always think about the carer, often informal, often not coded. So they need to be on our radar. But ideally, we'd be having our advanced care planning conversations with that carer in the room. So that's a great opportunity to ask them how things are going. So down at the bottom there, we've got some key useful bits. So we've got DNAR and respect conversations. And there's some really useful tricks and tips with regard to this when we're doing respect. So I normally save the coding bit until we've got the respect form, because once you've got the patient's priorities, it's much easier to have the resus conversation with them. So at this point, what I'll usually do is open the respect form link box and start completing the respect using that copy and pasted information that we put into the first box. And we'll go back to a bit of respect as we talk through. When we have completed box 4, that'll be when I ticked the respect box, having copied the contents of box 4, which then I can paste into the text box. That makes it visible. If you hover over the respect icon, straight away you'll see the box 4 contents. So it's really useful if you've got anyone querying what's on a respect form, rather than having to bring up the whole form. It'll give you that box 4 information straight away if you've got that paramedic on the line.
And that's if we hover over it in the patient demographic box over the R. Yeah. I've never noticed that. And which box do we need to have cut and pasted it into for it to appear? Is it this box?
That text box next to has respect. Once you click that, it will code it, and then the text box will open up for you, and you can paste it into there.
Okay, so clicking the pencil here to open the respect, the text box, and paste it into there. I did not know that. That's really, really useful, actually. Thanks for that.
And the other thing I do at the same time is go onto the home page and paste that same information onto the home page reminders section together with the date of the respect form, so that you know that the date it was created. So that can be useful if you've got a version control issue, if someone's been into hospital and come out with a new respect form, for instance. You've then got that information to hand to compare with.
That's good. These are really helpful, practical tips, Julie. So certainly keep emphasizing those. Anything else on the green page?
I think you'll see the ones about children there. We won't have many children, but they have much more detailed care plans, which where you could say the box 4 information is expanded. It still looks like a respect form. Not many colleagues will have seen one of these plans, but they are very detailed, and we're now incorporating those into EPaCCS when we get them.
Okay, good.
So we can go on, I think, now.
Okay. Oh, lots of.
Lots of. Okay, and people will see the slides. We're going to, I think, link it on the template page, shall we, Andy? So people will be able to see the slides after the event.
Yeah, I think depending on where people are viewing this, I think if they're viewing it within TeamNet, then we'll have the slides linked. So otherwise, we probably have some contact details at the end where people can request information.
We'll put them on the end of life toolkit as well. So we've now got a patient who's actively deteriorating, and this is where we do need to remember to update the care plan, the EPaCCS tool particularly, maybe the respect plan, depending on what's on there. But with a change of gear, those two things should always be at the forefront of our minds. So the information on here is very much relevant to someone who is actively deteriorating. The observant people who are used to EPaCCS will see that there's more on this page than there used to be. So the suction link, for instance, specific codes about hospice at home services. All these pages have preferred place of care and preferred place of death, recognizing that sometimes people's wishes change. So it can be updated there. If they haven't had the benefits sorted, again, that features on here. Anticipatory medications, this is the time that we should be thinking about prescribing for patients, because we don't know how quick they're going to deteriorate and when it would be needed. At the moment, we still have different forms for different areas of the county. Shortly, that will be one form for the whole county, at which time the EPaCCS template will be updated again.
So this is these boxes here, which link out to, I guess, open and mail merged form. Yes. I think
it does
for easy completion of DNS ones or ASS ones, depending on where you are in the county.
Yeah,
they're really useful.
Correct. Yeah, and anyone who's used this will also realize that if you click anticipatory medications, it takes you to a prescribing clinical template, which will default to the usual doses and instructions for someone who's naive for all the medications. Obviously, it will need changing if they're already on some of them at this point. But it saves a whole stack of time, and clinically it's safer as well.
Yeah, I agree, absolutely.
So you can record if you and when you're starting a syringe driver. There's different codes on there on the drop-down box. If the person hasn't yet got a respect form, it prompts you to start one. But for those that do have a respect form, it should be a prompt to review the existing respect form and make sure that it's still fit for purpose. Yeah. So good. We can go on to the red stage now, I think. Oh. Yeah, sorry, more clicks. Yeah, so we're now onto a patient that we think might be in the last couple of weeks or last days of life. There is some information about preferred priorities for care. That this current one says do not use. That's because the documentation is being finalized, but we do want people to be using it, and that will change and be updated very soon. Can I highlight here the GP authorizes nurse or accredited carer verification of death. Again, if we can save ourselves a whole stack of time by clicking this box, and I have asked for the link to the paperwork by which we can quickly complete that authorization on there. And the importance of this is saving coroner referrals and saving delays when someone dies, because a lot of carers particularly who have undergone training are able to verify death. And if we complete this and the carers know that we've authorize this. Again, it saves that phone call in the middle of the surgery to say, can you come out and see this patient, please, doc?
Absolutely, yeah. We're quite hot on filling that out now, because if you don't, then the nursing teams cannot verify, and they will get in touch and ask you to come out, or at the very least go in and then tick that box. So it's really vital.
Yeah. And again, we've got the respect information and anticipatory meds for those that need it, same as before, really.
Yeah, and I remember when we were just sort of preparing, something that struck me was the importance of getting the anticipatory meds done early, which, I mean, almost speaks for itself in terms of, they need to be there before they are required, but also that kind of signaling that it might give to partners and ambulance staff and out of hours that this is really an end of life situation, and just give them confidence to make that decision to keep the patient at home. And that makes sense to me in a way that it didn't before we had the conversation. So
yeah, absolutely. And actually, we do know that those patients who've had that prescription are more likely to be looked after in the place that they want to be, and not be transferred and die on a hospital trolley in the SDEC corridor.
Okay, absolutely. So, and then the after death page. Do you want to go through that?
Yeah, so a few things to comment on here. It links to the after death clinical template. Do you use that in your practice, Andy?
I must admit, we have a process in my practice where I think one of the admin team would fill in the initial information here, and then we have a separate template. I think we might have built it ourselves, or it might be that we use this medical examiner's reporting a death template, but we fill out some after death information, which our secretaries then kindly send along to the medical examiner, and then we get a reply back from the medical examiner asking for more information, or quite often actually suggesting that we're able to issue the death certificate as we've advised. But I mean, maybe that's out of scope for this session, and there've been sessions by the medical examiner about what to do. But anything to say on that, Julie?
No, I think our practice actually uses a very similar method, and use of that clinical template is really helpful, because it mail merges information subsequently, doesn't it?
Yes.
Through to things like the cremation form paperwork. So that's really helpful to use it. But not everyone across the patch knows how useful it is, which is why I mentioned it.
Yeah, it's really good, and it allows you to record whether there's a pacemaker in place and things like that, which is obviously really important to be recorded properly. So good.
Yeah, and actually you mentioned pacemakers and things like defibs. That is going to be appearing on the template as well, so that it will be coded and obviously relevant for including in the box for respect information about deactivating at a certain point.
Yes, very true. Yes, people don't want to keep getting shocked at the wrong time.
So the after death audit tool is useful again as a QI initiative for our CPDs and for registrars or any trainees. Lots and lots of learning with after death analysis. So yeah, it's really useful, and the coroners love it as well, because and CQC.
Good. And then we've got a slide here about box 4 on the respect form, and there is separate training around the respect form itself, but this is the sort of key box, really, isn't it, in terms of communicating the patient's wishes. And I know there's a slide deck which I think we probably ought to link to as well, that gives lots of examples of good entries in box 4. I don't know if you want to say a little bit about how important it is to get this right, and maybe give some tips about how we get the right sort of information in this box to get the right outcomes?
Yeah. So obviously it's got to be personal to the patient. So there's no one size fits all for this, but I guess the key question to ask ourselves when we're completing it is what kind of things that we know are important to support that person to achieve their priorities, whatever those are. And I suppose putting ourselves into their bodies, if you like. So our head with our clinical information into their position. How would I want to be looked after in that way? So it will be about foreseeable things that might happen. So if you've got a COPD patient, how would they want an exacerbation to be treated? Would there be any circumstances that they would want to go to hospital? If they're a person who wants all bells and whistles, would they want to be ventilated at the other end of the spectrum? So it's that kind of information. If they've got anticipatory meds in place, that's a key bit of information to put there. We've mentioned pacemakers. The ambulance crew are really keen that we are very clear and very specific about what kind of things warrant transfer to hospital. And for reversible conditions, I'm afraid isn't good enough.
And that's the most common thing historically in this box, really. And I can see how that creates a dilemma for ambulance staff, because actually just about anything is potentially reversible, I guess. It is. So is it that helpful?
Yeah.
One thing that struck me, Julie, looking at the examples that were given, that I think was quite helpful for me and the team, was just seeing that actually you know, writing in the third person about the patient is a good style, because sometimes you just wonder quite how to communicate it well. So, you know, Vic wishes, you know, writing in the third person, being kind of detailed and specific about what that person wants is really helpful, and actually, you know, you have a conversation and then articulate that in the box, and also sort of appreciating that there's no way that you can be completely comprehensive and cover every possible scenario that happens, but actually just a good amount of detailed information about some specific scenarios helps kind of build that picture, I guess, in terms of what that patient actually might want. And I imagine that crews can sort of extrapolate from that what they think they would want if it's not quite inside that scenario. So that's just something that we noticed and kind of thought at the practice, and that third person specific style, but not worrying about being entirely comprehensive, you know, was really helpful. So I think we'll be adopting that.
Yeah. The other thing to say about that is that we need to be discussing the contents of this with the patient and their key others. So whether it's carers in a care home, key family members, in this example, son and daughter who have joint power of attorney, they all need to understand the significance about this. And I found that if people understand the significance, they're more likely to treasure this form, because they can see that it's a key enabler in the right things happening.
Yeah, absolutely. And you're right in needing to involve the carers, because what you don't want to happen is the carers not having knowledge of the form, this being an important pivotal document at a crisis time, and there being some confusion, you know, about what happened, what is said. So yeah, absolutely, that's really helpful. Can
I mention just a small tip relevant to this? All our digital phone systems have the ability to prioritize patient numbers. When we have someone who's amber or red, it's worth thinking, could we prioritize a key number for that patient? Because if you do that, it makes a whole lot of difference in terms of the confidence of a patient to know that they're not going to be in a queue of 50 people waiting for a phone call when they need to contact a GP for advice. So just something to consider. In my experience, it's not abused. So
that's a really good tip, actually. I hadn't thought about that. And also actually making sure that everybody in the surgery is aware of the end of life icons in the demographic box, so that sort of receptionists and everybody can recognize when a person is end of life and at what stage, and kind of give them a bit of priority in terms of and caring in terms of how they're dealing with them as well.
Yeah, and patients will still say, and carers will say, when you ask them, that it's their GP they look to. There might be other services out there. Well, there are other services out there, but it's the GP that they really want to look after them. I know we're stretched, but it's still our bread and butter at the end of the day. And if we know that we've done a good job, then we feel a whole lot better about it.